Welcome everyone. My name is Alice Rothschild, and I'm on the steering committee of Jewish Voice for Peace Health Advisory Council. And this is a Jewish Voice for Peace Health Advisory Council webinar. We've done over 30 of them since we started doing this. And we're very excited. We have 72 people registered today, so hopefully folks will show up. And the title of today's webinar is Public Health Crisis in Gaza, the Impact of Infectious Diseases. And this is going to be a conversation with Dr. Amir Muharrab, who's Director, Research Program on Humanitarian Action, Global Migration, and Infectious Diseases at the Massachusetts General Hospital in Boston. So just a little background, we do webinars every 4 to 6 weeks since the genocide in Gaza began and all of the catastrophes emerged. And the format of today's webinar is that the speaker will talk for approximately 40 minutes. Then we'll have a Q&A. Well, I will be reading off the chat, questions that people have written and questions that have come up for myself. And so we do ask everyone to use the chat function and otherwise to stay muted at all times and to keep questions on topic and respectful. And in case you have, maybe been living in a cave and haven't figured out the chat function, it is at the bottom of your screen, and you click it and you direct your chat to everyone, and then you write your question and we will monitor that. And as you probably have noticed, this is all being recorded, and we will share it with all the people who've registered, as well as put it on our website and also send it out on social media. So I'm going to start with the introduction. Dr. Amir Muharrab is an infectious disease physician, as I said, at Massachusetts General Hospital and Harvard Medical School. He conducts research on infections in the context of forced displacement and humanitarian crises. He has experience providing medical care and leading research in humanitarian emergencies in a variety of international settings. So the speakers are all yours, Amir.
Well, thank you so much. I'm really grateful to be here today. Thank you for the kind introduction. Thank you for the really tremendous series of webinars that have been hosted and focused on health in Palestine in general, particularly in Gaza during this latest genocide. I was thinking to get started, I can present from some slides and then maybe move into more of a discussion and conversation if anyone has questions, or if we wanted to talk about one topic in more depth, because most of what I will present in slides will be an overview. It would be really challenging to go into a lot of depth on this. I do see people are still joining, which is great. But what do you think, Alice? Maybe I should get started now?
Yeah, because all these 27 people came on time, we should
Okay, great.
go
Yeah,
forward.
good. Well, I'll start by sharing my screen, and again, happy to discuss any of these particular topics in more detail. So hopefully you can all see my screen here, and I will start by talking a little bit about, or introducing for those who may not know, the concept of syndemic theory, and how I think it can be applied to war and international conflicts, and then specifically apply it to the genocide in Gaza. Now, syndemic is a term that was coined in the 1990s, shortened for synergistic epidemics. And it's really referring to how this interaction is observed between biological diseases, particularly infections, social structures, and then environmental factors that aggravate their effects on human health. Now, the classic example of a syndemic, when it was introduced in the mid-90s, is of HIV outbreaks. This was described in Connecticut, but it's applicable to many parts of the country and world, and how they relate to substance use disorder, addiction, sexual violence, injection drug use, and how each actually can exacerbate the other. And so that's why they are synergistic. epidemics. An epidemic of each one actually worsens the other. The labeling of it may have been new at the time, but the concept wasn't. It's sort of well known that the social interactions, the interaction between a social phenomenon and a biological disease can worsen one or the other, that individuals with disease are maybe subjected to stigma, which can worsen their social environment, which can then exacerbate their risk for contracting, responding, or curing infections or other diseases they may have. So while syndemics was introduced in the 1990s, a kind of older concept was that of structural violence that was um, introduced, decades before, popularized uh, by Paul Farmer and others in the 90s to think about how institutions and social hierarchies ingrain level of human suffering, inability for people to access basic needs or access necessary health care. So what is this concept that I think is really, really tangible to us on sort of social and community level look like at an international level, particularly with war? I think a lot about how infectious disease outbreaks occur in the context of war. And so I would kind of put it to you that when we think of war or international conflicts, there are syndemics of infectious diseases at the population health level. And they happen through a variety of mechanisms. War results, in addition to direct killing, to fuel and energy shortages, to currency inflation. Um, Aerial bombardment and demolitions may result in people getting displaced. Displacement may result in a change in the shelter type in housing instability, which can worsen infectious disease outbreaks either because of more congregate living or more interactions with individuals with different levels of immunity and infection. At the same time, what we see in the genocide in Gaza, similar to what we've seen in Yemen in recent years, is a population subjected to entrapment, not more than external displacement. And that entrapment through blockade and siege results in a tremendous volume of malnutrition. The, the large population of an already densely populated strip filled with mostly refugees from 1948 and onwards, um, displaced within the Gaza Strip, subjected to malnutrition, which is now becoming clear was a sort of deliberate policy of war inflicted by the Israeli military. And then on top of that, a variety of other either kind of long-standing economic factors like underdevelopment or environmental factors, particularly the acute shocks of climate change, can result in large-scale infectious disease outbreaks. This is what we've seen in other parts of the world, and certainly it's true of Gaza. But I would say that in many wars, that of which all of these may be true, we may not see large-scale infectious disease outbreaks as long as healthcare infrastructure retains some ability to do its job. And this really speaks to the advancement that infectious disease care have made over the past century, even the several last decades of implementing vaccination programs that address infections that really spread wildly in a population, implementing test and treat programs, public health interventions, particularly aimed at clean water or nutrition, really have an ability to blunt the effect of all of these syndemic factors, synergistic epidemic factors. But when healthcare infrastructure and personnel are targeted, that's when we see infectious disease outbreaks take hold. And so I want to talk about a couple of things to contextualize what I've just observed following everything over the past, 15, 16 months. And that's prior to October 7th, 2023, the Great March of Return and the COVID pandemic, and particularly its impact in Gaza. And then I'll talk a little bit about some of the infectious disease outbreaks that were reported from colleagues in Gaza since October 2023. For those of you who might recall, the Great March of Return took place between 2018 and 2019, a sort of initially spontaneous and peaceful border protests all along the Gaza Strip, which was met by mostly violence through sniping. So more than 200 people were killed by Israeli snipers, more than 6,000 injuries, which is a profound number over the course of just over a year, maybe close to 18 months of these set of protests. And a very consistent means of injuries that was widely reported were injuries, sniping injuries in the lower limbs. So, young people approaching the border fence, protesting, obviously largely peaceful, and subjected to sniping with gunshot wounds to their legs. And this included the deaths of several medics and healthcare workers who were there treating the injured. I've taken this photo from a published obituary of Razan Ashraf al-Najjar, who was a medic in her young 20s, who was killed by a sniper fire. And then here, second from the right on the screen, is Musa Abu Hassanain, who was also killed. Another young medic there. And some of you may have recognized in this photograph Tariq Lubani, who is a Canadian emergency medicine physician who was also shot while in the course of his healthcare duties volunteering in the Gaza Strip at this time. And for those of you who are more interested, Tariq Lubani has given a number of interviews and written articles about his experiences during this time. So I think the sort of shock that something like sniper fire, which is almost by definition a deliberate targeting of an individual by a belligerent actor, would hit a healthcare worker. I think certainly wasn't new in the Gaza Strip, but laid the foundation for what we would see a few years later. The other thing from an infectious disease point of view that's worth saying is the impact this has on kind of long-term quality of life for many young people in the Gaza Strip, where thousands were permanently disabled. Many had amputations of their legs. Medical evacuation denied for most people who required complex reconstruction, and then drug-resistant infections associated with external fixation. And I do remember reviewing an abstract that reviewed in the European hospital in the Gaza Strip the number of drug-resistant, multi-drug-resistant infections that were treated for individuals who had external fixation. And so for those who don't know, external fixation is really when a bone is shattered, which can be from fracture or, in this case, gunfire, and where rather than getting internally fixated, meaning an open surgery that fixes the bone, and then where you're left with orthopedic hardware inside, right adjacent to the bone, you actually have pins that go through and that fixate the bone externally, and then while waiting for the bone to heal. These often require multi-stage operations. And then because there's sort of an external piece of hardware that goes into the bone, they're susceptible to infections. And so, it's really that combination of violence. It can be exacerbated by malnutrition and already stressed healthcare system underdevelopment, but then the denial of what is available through medicine of life-saving medications, in this case, medical evacuations, that leads to sort of this synergy. Uh, you know, Perhaps when we talk about syndemics, the COVID-19 pandemic, both here in the US and North America and elsewhere, is easy to be brought to mind because this is where many social forces enhanced the epidemic effect of the virus. In Palestine, that was manifested as what many had named vaccine apartheid. That in Israel, access to vaccination was promptly and almost universally available. But in Palestine, it was not, even though Palestine remains occupied by Israel. An interesting note was that an exception was made that many Palestinian laborers who worked in Israel were vaccinated. Obviously, that is from a recognition that you cannot one cannot isolate a population from infections without protecting anyone who's interacting with it. We also saw attacks on COVID testing facilities, particularly in the Gaza Strip, in the early years of the pandemic. What was notable to me, kind of observing this stark vaccine apartheid in Israel-Palestine during the COVID pandemic, was the language and of the medical community, particularly with erasure of Palestinian sort of um, agency or involvement here. So there were many in the United States, for example, and around the world, who talked about how Israel successfully vaccinated its entire population, or more than 95% of its population. Of course, the population it's responsible for, being an occupying power, is much more than those who are inside, 1948 Israel. And this was seen in the academic literature. So I'll just give one of numerous examples. This article that came out last year that talked about the impact of COVID boosters if the US had matched Israel's speed and uptake of COVID-19 vaccination. They're saying if they had matched what was seen in Israel. Now, of course, what they ignore is that Israel sort of deliberately denied vaccines to a racialized minority of people that are under its control and occupation. And so if the US had done that, then of course their estimates would be very, very different. What's also interesting is academic censorship. I won't stick on this too much, but at the time, um, uh, a letter was published by the medical journal The Lancet on the structural violence, that term I had kind of introduced earlier, in relation to the pandemic and in the Gaza Strip. What's notable for me here is this is probably the only time that I have recollection of that a journal sort of pulled or retracted or made an article or disappear without having sort of scientific grounds to remove it. It was really removed from the Lancet website on the grounds that it sparked a lot of controversy after it was published, and that the journal was, uh, according to this sort of follow-up article by the authors, not prepared to engage um, with the uh, uh, controversy or the sort of coordinated efforts and coordinated complaints, and even potentially legal action of individuals who are upset with the conclusions of the research letter. So those who are interested could read more in this blog post that described the whole circumstance here, and this was all in 2021. So so turning now to the past 15, 16 months or so in the Gaza Strip. As is known to this crowd, the first 100 days of the genocide were among the deadliest seen in any war in recent memory. These are the kind of total number of deaths and then the child fatalities per 100,000 people. So really dwarfing many very deadly and devastating wars in recent years. Um, but related to infectious diseases is, in addition to the kind of direct killing, the forced displacement, was also the destruction of infrastructure that's necessary for public health. So this is satellite images that were compiled by a colleague that I'm proud to work with, who wrote about this in the Independent last couple months ago. If you see here, this is a water treatment plant, one of the bigger water treatment plants in North Gaza. And it is powered by a number of generators and solar panels, which you see here, encased in red. And then these same parts in red show that within a few months, there was evidence of damage of both solar panels and generators. And so, of course, this water treatment plant was put out of service within several months of the genocide. The strategic need to attack um, solar panel that provides electricity for a water treatment plant is unclear unless the goal is really to, devastate the population and facilitate the spread of infectious diseases. As is sort of well documented now, nearly every hospital was attacked since October 2023, some being put fully out of commission, the rest partially incapacitated. Numerous humanitarian clinical sites, multiple ambulances, and of course the kidnapping of many healthcare workers. So that is an essential component, in my view, of what I call conflicts endemics or wars endemics, an essential component for the spread of infectious diseases. These are some numbers that honestly probably need updating, but more than 1,000 separate attacks, more than 1,000 healthcare professionals killed, more than 300 arrested and detained, and even some remain in detention. From the London School of Hygiene and Tropical Medicine, jointly published with the Hopkins Center for Humanitarian Health, were a set of scenario-based health projections. The first one published in February, a subsequent few published since then, including one recently on malnutrition, where they use a variety of sources to project the epidemic and non-epidemic causes of death under scenarios of ceasefire, status quo, and escalation. And so this is a group that has done great epidemiology in this issue. And in addition to sort of projecting the rise of maternal and neonatal mortality, several infections of epidemic potential, including meningitis, cholera, measles, and polio. These were all kind of simulation studies thinking about, well, if there were different scenarios, what would be the kind of likely probability of having an epidemic. And sure enough, we can think about polio, as we know, and as I'll talk about in a little more detail, was identified in the Gaza Strip last summer, so months after this was published. And then I won't go through this in detail, but they also kind of project a range of possible excess deaths related to various epidemic and non-epidemic causes. So I want to talk about a couple of things in detail. One is hepatitis A. Hepatitis A is a virus that infects the liver. It's transmitted when people consume contaminated food or water. Um, uh, Between October 23 and I think the summer or early fall of 2024, more than 100,000 cases of acute jaundice were identified in the Gaza Strip, and most of these were likely acute hepatitis A infection. So hepatitis A is a vaccine-preventable infection, with most of the population in Gaza vaccinated against it prior to the war. And so as hepatitis A spread, it really spread like wildfire because, as many of you may have seen in images, um, water, including wastewater, sort of pooling the streets of many tent cities, and children, particularly babies who were non-immunized or under-immunized. Perhaps they did receive the vaccine at some point, but then through malnutrition and even trauma and stress, impacting their immune system, become less immune to the virus. And so it is a highly infectious disease and spreads through the combination of displacement, crowding, destruction of water infrastructure, the destruction of healthcare facilities, and then restrictions in humanitarian aid, as well as malnutrition and dehydration. This is the epidemic curve over time. So these are the sort of weeks of the year. This is the latter part of 2023, and then the weeks of 2024, showing that there's, as we expect in these kinds of epidemics, a real uptick in the rise of the number of cases of acute jaundice syndrome. Now, these are cases that are diagnosed and reported in the humanitarian situation reports from the Gaza Strip. There is clear that these are underreported. And anecdotally, many clinicians I've spoken to said that when they were working in various hospitals in Gaza, almost every child that they saw had yellowing of the eyes, that it was just so common there. So let's talk a little bit about poliovirus in particular, and I'll give a background about the poliovirus and talk about how about what happened in the summer and fall in the Gaza Strip. Polio is a virus that causes acute flaccid paralysis, so infects the nerves, which impacts the ability for someone to use their muscles, and that's what the term flaccid paralysis refers to. Um, for decades now, we've had a global polio eradication campaign that has rested on the use of vaccination. Wild polio virus, meaning the sort of original type of polio that circulates, is present really in over the last few years, mostly in just two countries, in Afghanistan and in Pakistan. But there's another kind of poliovirus called circulating vaccine-derived poliovirus, which can also cause clinical disease. And that is more commonly found, particularly in underdeveloped or war settings. So there are two kinds of polio vaccines available. The inactivated poliovirus vaccine, which many people in North America and Europe receive, and then the oral polio vaccine, or OPV, which is um, uh, more often used in international settings, particularly in resource limited settings. The reason why the oral polio virus is used is because this vaccine uses a weakened form of the virus to expose the body's immune system to what the virus could look like, building up the immune protection against the virus. It's an oral vaccine, meaning it's um, directly acting within the gastrointestinal tract, which can sort of strengthen the immunity. And it is shed in the stool by someone who is vaccinated, which can spread to close contacts and actually provide a sort of passive immunity to close contact family members. It's also much more affordable and easier to scale up in a response setting or in a low resource setting. And so that's why the oral polio vaccine is used more in these sort of settings than the inactivated polio virus vaccine, which is the shot that many people in say the United States receive. The problem with the oral polio vaccine is that if an individual is vaccinated with it and they shed it in their stool, after it being sort of retained by the next family member and then shed in their stool and then retained and then shed and then retained and shed, after several generations of that, there is a chance it can revert to a more virulent form of the virus. It can sort of revert back to the type of virus that causes clinical disease. So that typically happens when that sort of spreading happens in a very unvaccinated population. So oral poliovirus vaccine programs really require good coverage for this to sort of never happen. So that's the background. Poliovirus is sort of a complex public health issue. It's actually also very controversial within the medical community what the best way to eradicate and or address it is. And thinking about the timeline of what happened in Gaza, in July 2024, um, the vaccine-derived polio virus of serotype 2 was identified in the wastewater. And it was identified actually in several different wastewater testing sites in the Gaza Strip. Um, and so this, I mean, it was even just tested because there was certainly a suspicion that it would be a matter of time before polio would be found in the wastewater in such a crisis with densely populated, displaced persons from Gaza and undernourishment, malnutrition, essentially being used as a weapon of war, and then of course the destruction of the water sanitation system. Remember, at the same time, Israel limited or often just denied the importation of chlorine into Gaza, and that has the effect of limiting people's ability to sanitize water, so that Palestinian doctors from early on in the genocide were stating that women were using dirty water to mix with formula feeding, the widespread consumption of dirty and contaminated water. Polio virus is not inactivated by heat very effectively, and so it is really one of the viruses that can spread in this situation. Immediately after it was identified in wastewater, the Israeli military offered the polio vaccine to all of its soldiers, particularly those returning from fighting in Gaza back to Israel. And so these would be vaccine boosters for adults who were already vaccinated for the most part and being exposed to contaminated wastewater. And then, as many of you may know, in August 2024, a case of acute flaccid paralysis was diagnosed in a 10-month-old child in Gaza. This was the first case of polio in Palestine in about 25 years. So the population in Gaza in particular had previously had a very high vaccination coverage against polio and other vaccine preventable infections. And so this was really a notable incident. And then between September and November 2024, a massive polio vaccine initiative was implemented in Gaza. It was stopped because of ongoing sort of Israeli attacks, pauses that were sort of unplanned due to escalating violence. But I would say it's a pretty remarkable achievement that they were able to vaccinate so many hundreds of thousands of children in several rounds of vaccination campaigns in those few months. The unfortunate side of this sort of intervention, like there are in many public health interventions, and this might be what I close and finish with in terms of the slides, is that this was an incredible coordinated public health intervention that was aimed at reducing the risk of one single infectious disease, granted, albeit one with the potential to really paralyze large numbers of both children and adults. But this required coordination with an overworked and under-resourced healthcare staff in the Gaza Strip, as well as the Israeli military authorities and a number of international humanitarian agencies. Unfortunately, we know that many of the children who are vaccinated in this program would go on to suffer either from other infectious disease um, uh, uh, maladies like hepatitis A, which I mentioned, also meningitis, respiratory viruses, which have been very, very common throughout this period of time, or may directly be killed and by direct fighting and ongoing demolition of homes and destruction of the Gaza Strip. And so the question is why this public health priority was sort of elevated and implemented above all the others. And as has been sort of discussed, the rationale may be because of how a polio virus outbreak in one country, in one region, can rapidly spread to adjacent regions. Israel itself has a large hundreds of thousands, maybe close to 200,000 individuals who are under vaccinated because of religious exemptions and who would be very susceptible and are routinely susceptible to kind of periodic polio virus outbreaks. But one that, say, was brought in either by Israeli soldiers or sort of transmitted through Israeli contractors or other people going between Israel itself and the center of fighting within Gaza would potentially sort of devastate that under-vaccinated population. And so I think that's one hypothesis for why the vaccination campaign against polio was so successful in light of many, many other public health priorities being neglected or sort of actively not just deprioritized, but attacked and undermined. So I think that's where I'll end these slides, and I'll stop sharing. Um, if we want to discuss about any particular topic of infectious diseases, or maybe think about where things go in the future, I would be very, very happy to discuss. And again, thanking all of you for joining and talking about it today.
Well, thank you so much. This has been very informative. I'm going to take one of the questions and put it together with some other questions because there's a lot of wondering about vaccines. So let me just ask these and then you can talk. What percentage of very young kids in Gaza got their first Hep A vaccine and then couldn't get the second one uh, due to the genocide? This is obviously probably true for all childhood vaccines that require multiple doses. So is there any information on the impact of vaccine interruption on development of immunity? And then there is also, other diseases that are usually controlled by vaccines, like is there an outbreak of measles? Why wasn't the measles vaccine folded into the polio vaccine? Um, I've also heard that there's now been an assessment of the polio vaccine and the question of whether there's going to be another vaccine campaign because not everybody got vaccinated and the level of immune response is less in malnourished children, all those kinds of issues. And then I'll just end with this, that has anyone written a paper on the specifics of Israel denying routine vaccines on children as an act of genocide, since it seems that there is genocidal intent? So that's a lot, but I thought you could fold it all together.
Thank you. Those are really, really good questions. I would love to give kind of a quick background on these multi-dose vaccines. So there is, whenever a vaccine comes out, like the childhood measles vaccine and some of the other ones you mentioned, there are studies done to sort of understand what is the best or most optimal timing of the vaccine and how many doses are required, to sort of minimize the doses required or optimize the timing to make it coordinated with other vaccines. Because in the sort of public health world, when we give several interventions at one time, it's more likely to be accepted by the population. If we require someone to come back every month for a new vaccine, there's a good chance that people are just going to stop coming back and we're not going to be able to immunize them. And so something like measles, hepatitis A, these are sort of tried and true vaccines. They've been studied. You, especially as a child, you really need the multi-series to be completed to have long-term immunity from it. So a child who receives only one dose of the measles vaccine or one dose of the hepatitis A vaccine are basically considered not non-immune, or there's a good chance that they may not have lasting immunity. They are more immune than someone who's never received any vaccine, but they are not considered to have long-term immunity. And there may be more accurate information out there, but from the colleagues I have spoken to, many of whom had worked in Gaza, they said that the vaccination program in the months immediately after October 7th basically came to a halt. Routine vaccines were deprioritized, as would be expected, because the health systems were engaged in responding to a really unprecedented level of needs, acute needs, life-saving needs, and so preventative care like vaccines were halted. Um, I'll give you another factor that played into it based on what was reported to me was the um, closure of or electricity and energy importation. Um, that in particular had a large effect because many hospitals had to end up relying on their own generators of electricity, which often rely on fuel. As fuel decreased in its availability, some of the generators would only be on for part of the day or part of the night or something like that. And that could be extremely detrimental to a vaccination program because our vaccines require refrigeration. Some of you maybe remember reading about the novel COVID vaccines a few years ago required really, really cold temperatures to remain active. Most of these routine vaccines just require refrigeration at a certain point, but when that refrigeration is compromised, the vaccine could be inactivated. In many parts of the world, clinicians will often still give the vaccine if there's no other option in the hopes that there's some activity. But the truth is, having an interruption in what's called the cold chain or the refrigeration of a vaccine has a big detrimental effect. So I think those two factors in the very, very beginning had a big impact. As humanitarian organizations and Palestinian sort of health workforce really innovatively responded to the crisis. Vaccine programs did start particularly for, say, women who were pregnant, children who were in Rafah. There was a vaccine program later on in 2024, and so there was limited vaccination programs sort of throughout the pandemic. I have not seen throughout the genocide, but I have not seen sort of formal data on what percentage of children completed the series throughout the last 15 or 16 months. Um, but if I get that or find that, I would be interested to kind of bring that back to the group because it would be really, really important to know. And that's the other thing that sort of can be unseen about an effect like this is under normal circumstances, a health ministry really documents vaccine program effectiveness to understand where the gaps are and where responses should be made. And that's another thing that's lost in the middle of a war like this is that we lose track of who needs vaccines, of what programs might have been compromised, and so on. To the quick question about has anyone written a paper of the specifics of sort of vaccine denial or vaccine being withheld. I could guarantee you people have written papers about this in the medical in the medical world. I and a colleague of mine um, uh, wrote papers about this. I wrote I would say during the COVID vaccine issue as more and more articles were coming out saying lauding Israel for vaccinating, all of its population or 99% of its population. I worked with an Israeli colleague, a Palestinian colleague, and together we wrote what I thought was a pretty reasonably worded paper outlining how, we risk neglecting a part of the population when we use this language, that Palestinians under occupation really depend on the occupying power for their health. This is rooted in the Geneva Conventions. And actually that we can broadly look at the world and see a disparity in vaccination program. And, the COVID pandemic taught us that all our health is tied to each other. And we had all these principles in the beginning of the pandemic. And that article was certainly not published, I will say, denied from one journal to another. I've had other colleagues write about this, but it hasn't been published. So I don't think this is a place where in the medical literature there is going to be much written about it. And then I mentioned also before those group of public health experts and clinicians who wrote about COVID in Palestine, who actually had their articles sort of disappear from the journal website. This is a prestigious journal. I've never heard of that happening in cases where there wasn't just scientific misconduct or a problem with the data or something like that. So so more than one unprecedented thing as far as the medical outlook in Palestine goes. There's certainly exceptions here that are not seen in other parts of the world.
So do you have, this is a sort of in response to what you said, any idea of the forces that are put upon a journal for them to behave in that way? Because there is this, Israel exception that we see throughout our culture. Do you know what the forces are on academic journals that theoretically are supposed to be science-based and academic?
I've asked colleagues of mine who work in editorial boards for some of these, some prestigious medical journals who I'm certain, and actually we can verify, received um, submissions of articles specifically talking about what's happened in Gaza, and who've published about other healthcare issues related to, social issues in healthcare, like racism in the United States, like war in Ukraine, like war in Yemen. I had an article published about malnutrition and the attacks of healthcare facilities in Yemen. Um, uh, and that was published after a lot of back and forth with peer reviewers. Some of my colleagues who are on editorial boards really talk about explicitly about how this would end up bringing in a complexity that they don't have the capacity to handle. Um, they've noted to me that um, there are more concerns about sort of the political ramifications of this, that maybe this is a topic that moves from healthcare and public health into politics, but they can't really square that circle when when addressing the fact that, many medical journals, even there's one medical journal that published a guidance from the American College of Physicians on firearms and gun violence in the United States. And that was a clearly political statement, but it was a political statement that had to do with health. Um, I'll just, if that's okay, Alice, I'll just give a
Sure.
second about that. That was I think in maybe 2017, 2018, around that time, the American College of Physicians published this guidance about firearms, and they said many kind of political statements, which I support. One is, and these are not controversial, I would say, in the healthcare community, but that we should track public health data about firearm violence in the United States, that we should counsel patients about firearm safety, that pediatricians should ask parents about gun safety and that is there a gun in the house and that kind of thing. In response to publishing that, the NRA, the National Rifle Association, famously tweeted something about how doctors should stay in their lane. And the medical community took that and really went with it at the time. There was all these social media posts where people showed the blood of emergency department floors after a gunshot wound victim came here and said, "This is our lane. This is why we care about this." Um, and I thought the healthcare community was galvanized by this. In the city where I work in Boston, hospital leaders with their hospital brands and insignia did a joint street demonstration arguing for gun control reform and so on, and saying this is our lane. This is and they had a heyday of physicians meeting political meeting the political and social needs of their patients. All of that is forgotten. Amnesia across the board when it comes to war, not just in Palestine, but in other places. But I would say particularly in Palestine, where suddenly people are, this is political. I would say now in Boston, many healthcare institutions have adopted positions of political neutrality, saying that they won't speak up about an issue that might offend or affect one person or another if it's too political. So it's really gone. I mean, I've sort of gone off track here, but it's really gone a big reversal. But ultimately, this affects people's lives. The denial of a vaccine, as was sort of noted in the chat here, really impacts such a big part of the population. And if this isn't in our lane, then I don't know what is.
Well, thank you for diverging off track. That was very good. So I'm going to ask two more questions here. Is it known whether the spring-summer hepatitis A outbreak has subsided, and if so, how? And then another question on any data on infections related to trauma, direct inoculation, and aerosolization of particles from bombing, such as mucormycosis.
Great questions. Great questions. I actually, that second question reminded me that you had also brought up measles. One of the
Yeah.
reasons that the polio virus campaign was prioritized, I think, before more than say like a measles campaign or something, is because um, it's possible a measles campaign may not directly impact Israeli society as much as a measles outbreak may not directly impact Israeli society as much as a polio virus outbreak. Yeah, a polio virus outbreak, because it's transmitted person to person through contaminated water, and an individual who gets contaminated may be asymptomatic and shed active polio virus for a long time. Imagine a soldier, a government contractor from Israel or something like that, then going back into Israeli society and shedding it. It's a little different than measles. Measles is very, very infectious, but it requires a closer person-to-person contact. It's spread, we think, through respiratory, kind of airborne aerosolized. So someone would really need to be up to a child with measles to have that. The other thing is we know that there's underdiagnosis of a lot of these conditions. So there could be a measles outbreak in Gaza, but it would require a child to have a fever and a rash to go to a doctor who has the ability to diagnose measles, to do a lab test on measles or to maybe diagnose it clinically. We know that there's been a lot of in this sort of setting is very common, a nondescript sort of respiratory infection or something. So some of those may have been a severe condition like measles, but the lack of diagnostic testing would have been limited there. But let me get back, Alice, to to the questions you raised. Actually, I forgot the first part of the question. I don't know. Sorry if I can ask you to just
I'm
repeat that
sorry.
one.
Let's see. The first part of the question was
Oh, if the
the
hepatitis A
hepatitis A.
outbreak subsequent.
Yeah.
Yes. Yeah. One of the things that may have happened with the hepatitis A outbreak is there's a chance that it may have spread so efficiently and affected so many children that it um sort of kind of burned through
Self-immunized, right?
the population, sort of immunize the population there. That is not the way we want to immunize the population through direct infection, because it means that many of those kids suffered, many of them suffered liver damage. Probably many of those children died. For this volume of hepatitis A infection, we know that some of them probably died of the liver damage, or maybe the liver damage compounded with malnutrition and another infection or another issue resulted in that. And then probably also impacting women who are pregnant who may have been underimmunized or so. Having said that, there was a report I read of doctors in November or December working in one of the hospitals in North Gaza, where the doctors still reported a lot of children having kind of yellowed eyes. Um, and so if you read the situation reports from Gaza over the subsequent few months, there was less reporting of acute jaundice syndrome. It's unclear to me if that were because there were less cases or because they ended up just reporting different things with all of the limitations in their resources and ability to to sort of report there. And then someone brought up mucormycosis, and this is a fungal infection that can be really, really deadly, particularly in people whose immune system is not as strong. And so I think that's worth bringing up because often when we're talking about things like infectious disease outbreaks, we're really focusing on the majority of the population or the population that is sort of best able to withstand these outbreaks. But in any population, people who are living with disabilities, people who have vulnerabilities, people who are maybe were previously under treatment for cancers, someone who may have gotten a transplant at one time, they are much more vulnerable than the rest of the population. And so doing something like taking them and having them live in a shelter with less nutrition, with poor access to medicines, can greatly impact their health and their susceptibility to these kinds of infections. And it's really, really easy to sort of not count that part of the population. I mean, there is an analog there with COVID here in our society, in our community as well. As COVID was sort of declared over, there were many people in the United States who were still kind of suffering the effects of it or who were more susceptible of it because of their comorbidities. I um, visited in Egypt a patient who was evacuated, one of the few who were evacuated from the Gaza Strip, who had a kidney transplant and who had suffered sort of the traumatic effects of being near one of these large sort of bunker busting bombs. Basically, was sort of thrown out and had his sort of half his body impacted by this trauma. Eventually was able to get evacuated into Egypt, but the state of his kidney transplant was nearly lost because of all of the sort of uh, medical complications that he was subjected to, including infections and delays in evacuation, delays in care, in addition to sort of just trauma to his direct injury to his internal organs themselves. And that's another thing to sort of note, in many of the life-saving surgeries that have occurred either because of burn wounds or trauma wounds, things like mucormycosis, like this fungal infections, or just drug-resistant bacterial infections can complicate the recovery of any of these infections.
So I have two last questions. We sort of touched a little bit on the impact of being malnourished on being able to mount an adequate immune response. And I'm wondering if there are any studies on that or any studies on the impact, the efficacy of the polio vaccine in Gaza, because this was given to kids who were already malnourished and traumatized. And the other last question is, we've heard nothing about COVID since the genocide started. Is it because it's the least of their problems, or do you have any data on, I mean, people living all together in tents and malnourished, you'd think there would be a COVID flare.
Two great questions. You know, I'll say in the medical literature on poliovirus, there is some uh, well-conducted studies from India that showed that children who have chronic diarrheal illnesses from like gastroenteritis and on top of that, some markers of malnourishment respond to the polio vaccine much worse. And so I think that is the best data we have to sort of infer about the impact of the vaccination program in Gaza. You know, you want the best immunity for the most number of children. We probably didn't receive that even with this incredible campaign, and I truly think it was heroic what some of the families and the healthcare workers did in Gaza between September and November 2024 to vaccinate so many children. But we know that many of those children probably had diarrheal illness, were undernourished by just even the most conservative markers of nutrition, and so probably didn't respond as well as we wanted to, in addition to the actual delays of the campaign because uh, of of Israeli fighting. Um, so, to my knowledge, there was no sort of follow-up markers, like say doing a blood test of children who are vaccinated to try to see how many of them actually mounted the expected immune response. In this stage of ceasefire, I think that would be a really important addition to the literature, because I've held, as many health professionals and COVID and polio experts have, that having a sort of single disease mindset is really inadequate in a situation like where Gaza is. The polio vaccination program is important, but it's also important for kids to not die under the rubble or not get subjected to, hepatitis or any of the other maladies that we've been talking about. The question on COVID is a great one, and if you see how the situation reports throughout the last 15 months have documented, they've often had kind of tallies or cases of respiratory viral illnesses that presented to an UNRWA site, a humanitarian clinic site, MSF clinic site, Med Global, one of these sort of clinical sites. And so one of the biggest outbreaks has been in respiratory infections, respiratory viral infections, in pneumonia, and then even sort of a portion of that ended up progressing to meningitis, infections of the spinal cord. So probably the respiratory infection um, uh, tally included COVID in addition to seasonal influenza and a bunch of other viruses. But I would say it's most likely testing limitations that prevented a specific diagnosis being assigned. Um, to not to over answer the question, but other studies have been during the COVID pandemic were done about how COVID spreads in refugee camps in outdoor crowded settings, including Cox's Bazar in Bangladesh, where the Rohingya are, in others around the world, and it seemed like there was a less than expected burden of COVID specifically than would be otherwise have been expected in these camps. And there was a lot of reasons thought to contribute to that maybe having a young age of people who frequently get exposed to seasonal coronaviruses imparts some amount of immunity, um, uh, you know, relative to, say, older individuals who are locked in a house who aren't exposed to coronaviruses frequently. Um, but the respiratory infections have been bad. Another thing that I didn't mention that have been particularly debilitating are skin infestation, skin diseases. The availability of soap and clean water um, is enough to sort of keep many uh, 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 like many to prevent an outbreaks of skin infection. But in many of the displaced parts of Gaza, there was essentially no soap available for children. Severe skin infections that actually sort of end up behaving more like burn wounds or some of the things that were reported, and then outbreaks of infestation. And this is I've treated this in other sort of refugee and migration contexts around the world, a particularly traumatizing and stigmatizing condition for families to live with, where they're often sort of saying like, we are clean, we're clean people. Why are we having this, or why is my child sort of itching to the point of breaking out part of their skin? And it's really because of the circumstances they've been put under, the sort of syndemics or structures that have contributed to them being there.
Well, thank you very, very much. This has been quite wonderful, and I think we're really getting a look at the impact and the interactions between medicine and politics and racism and all of those things coming together. So just to wrap things up, I do encourage everyone to go to the website, jvphealth.org, and sign up so you can get our updates and our action alerts. We are currently putting out a weekly urgent medical update on Gaza and the West Bank that is sent to our email list as well as posted on our website and in social media. And if you sign up on our website, you will automatically get these. And then we do a lot of other advocacy writings and urgent actions. Going forward, on March 8th, we're going to have a webinar with Faris Jackaman from Mondoweiss talking about their work and what they're learning about the situation, including Lebanon. And then on April 5th, we're going to be hearing from Alex Smith, who is the USAID contractor, formerly an organization we supported, who resigned from the State Department because he was attacked for talking about neonatal and infant malnutrition in Gaza. And then in May, we're going to hear, I don't have the exact date, from Sam Rose, who is the acting UNRWA director in Gaza. And we want everyone to feel invited to become more active in JVP Health Advisory Council. Again, you can sign up on the website, and please fill out the feedback form that we put in the chat and let us know if you had any questions. So thank you so much, and thank you everyone for hanging in there and listening to this wonderful presentation. Thank you.